Welcome, everyone, to the Rad Onc Smart Review CNS Cancer series.
Great to be here.
Today, we're jumping into a really crucial tutoring session, looking at something that's, well, completely changed the landscape for brain tumors.
Absolutely.
We're calling it modern classification and anaplastic oligodendroglioma evidence.
Sounds good.
And our mission really is twofold. First, we want to lay out the essential, modern diagnostic framework for gliomas. How do we even think about these tumors now?
Which is critical because it's totally different than it was, say, 10, 15 years ago.
Exactly. And then right after establishing that framework, we'll immediately apply it. We're going to detail the evidence-based management for a specific type, anaplastic oligodendroglioma.
Right, digging into the two big landmark trials that define how we treat it.
Because there's been this molecular revolution, hasn't there?
Yeah.
It's completely rewritten how we understand high-grade gliomas. Accurate diagnosis now is molecular diagnosis integrated with histology.
Couldn't agree more. It's moved beyond just looking at slides. We're understanding the fundamental biology now. It dictates everything. And to make this really concrete, let's maybe start with a quick case, something pretty typical you might see.
Okay, sounds good. Anchor us.
All right. Imagine a 42-year-old man. He presents with about a 6-month history of seizures, focal seizures, getting worse.
Okay, 6 months, focal seizures, classic signs.
Yep. So he gets a brain MRI. It shows a pretty large mass in his left frontal lobe. It's non-enhancing, which is interesting, and it has calcifications.
Non-enhancing calcifications. Already given some clues. Maybe pointing away from the most aggressive types initially.
Potentially. And those calcifications, tiny calcium deposits, they're often seen in certain glioma types, like oligodendrogliomas, though not exclusively.
Got it. And location. Left frontal lobe could be tricky.
Very tricky. Let's say it's right up against the motor cortex. So the neurosurgeon, understandably, performs a subtotal resection. They get out as much as they safely can.
Right, makes sense. Balancing tumor removal with function, a common scenario.
Exactly. So surgery's done, pathology is pending, and your neuro-oncology colleague calls you, asks for your initial thoughts.
Ah, the classic what you think call while waiting for the path report.
Precisely. And this is where it all hinges. It looks like a high-grade glioma presentation, but what you do next, your entire management plan, is completely dependent on that final integrated pathology. Without it, you're really just guessing.
Yeah, you can't make a plan without knowing exactly what you're dealing with, especially now.
That's the core point.
Okay, so let's unpack that. This paradigm shift in diagnosis. You mentioned it's not just histology anymore. For years, we had these names based on looks. Anaplastic astrocytoma, anaplastic oligodendroglioma, glioblastoma. And I remember seeing anaplastic oligoastrocytoma all the time. That diagnosis caused so much confusion.
Oh, definitely. A real headache. Thankfully, it's pretty much obsolete now.
Because the WHO, the World Health Organization, came out with new classifications in 2016, updated again in 2021. They mandate this integrated approach, right? Combining the histology with key molecular markers.
That's it, exactly. It's histology plus molecular genetics.
So when that path report finally arrives for our patient or any glioma patient, what are the absolute first, most critical molecular questions we need answered? What's step 1 and step 2?
Okay. Excellent question. This is the foundation now. The very first thing you look for, the absolute key question number 1 is, what is the IDH status?
IDH, isocitrate dehydrogenase.
Correct. Is that gene mutated or is it wild type, meaning normal? This single piece of information fundamentally splits gliomas into 2 completely different diseases. It's not subtle. It's a profound biological divide.
2 different diseases entirely based on one gene status.
Essentially, yes. It changes cellular metabolism, how the tumor behaves, prognosis, treatment response, everything.
Okay, so tell us about those 2 pathways. What happens if it's IDH mutant versus IDH wild type?
Right. So if the tumor is IDH mutant, these are what we now consider the kind of true diffuse gliomas. They tend to show up in younger patients, 30s, 40s, like our case example. And crucially, they carry a significantly better prognosis. They generally grow slower, respond better to therapy. It's just a different natural history.
Okay, better prognosis with IDH mutant. What about IDH wild type?
Now, if it's IDH wild type, no mutation, things are different. Even if the histology looks lower grade, like a grade 2 or 3 under the microscope.
Yeah.
Clinically and biologically, these tumors behave like glioblastoma, full stop.
Wow. even if it doesn't look like a GBM pathologically.
Exactly. We now call these molecular GBMs, and unfortunately, their prognosis is poor, mirroring conventional glioblastoma. We'll actually dive deep into those IDH wild-type tumors and their specific management, the STO protocol, and all that in episode 3.
Okay, important distinction. So IDH status is the first major branch point. Crucial. What's the second key molecular question, assuming we've gone down the IDH mutant path?
Good clarification. This second question only applies if the tumor is IDH mutant. If it's wild type, you're already heading towards the molecular GBM category. But if it is IDH mutant, then you need to know what is the 1p and 19q status.
119q. That refers to chromosome arms, right?
Correct. Specifically, the co-deletion of the short arm of chromosome 1p and the long arm of chromosome 19q. This specific combination, this co-deletion, is the definitive molecular signature of an oligodendroglioma within the IDH mutant family.
Ah, so this is how we finally separate the IDH mutant astrocytomas from the IDH mutant oligodendrogliomas cleanly. It's the 1p19q status.
Precisely. It cuts through all that old ambiguity. If you have an IDH mutant tumor and it's 119q co-deleted,
Then it's an oligodendroglioma.
bingo, oligodendroglioma. Now, if you have an IDH mutant tumor, but the 1p and 19q are intact, no co-deletion,
Then it has to be an astrocytoma.
astrocytoma. Simple as that. IDH mutant, 1p19q intact equals astrocytoma. It provides such clear diagnostic bins, which is essential for picking the right treatment path.
That really clarifies things. It feels much more objective than just relying on how fried egg their cells looked under the scope.
Exactly. Though histology still matters for grading, these molecular markers are the defining features for the type of glioma.
Okay, now, you often hear ATRX mentioned alongside these. Is there a quick clinical pearl or maybe a mnemonic to tie IDH, 1p19q, and ATRX together? Something easy to recall in clinic.
Yes, absolutely. There's a very useful relationship here. A 119q co-deletion and loss of ATRX expression, typically detected by immunohistochemistry showing the protein is missing, are almost always mutually exclusive.
It's mutually exclusive, meaning if you have one, you don't have the other.
Pretty much, yes. It's a very strong inverse correlation, and loss of ATRX expression is a key hallmark of IDH mutant astrocytomas.
Ah, okay, so the pearl is...
The pearl is, if you see on the path report that the tumor is IDH mutant and it shows loss of ATRX, you can be very confident it's an astrocytoma. And because it's an astrocytoma marked by ATRX loss, you already know it won't have the 1p19q co-deletion. It's a quick way to confirm the astrocytoma lineage.
That's a great shortcut. So IDH mutant plus ATRX loss points strongly to astrocytoma and intact 1p19q.
You got it.
Okay, maybe a mnemonic then. To remember the sequence, IDH first, then 1p19q for the oligoastro split. Maybe think about ATRX confirming the astropath. How about IDH-ONE, IDH first, then O for oligo, defined by the 119q co-deletion, maybe NE for not expressed ATRX in astrocytoma, or just IDH, then 1p19q, and remember ATRX goes with the astrocytoma.
Huh, I like IDH-ONE. It emphasizes the key markers in order IDH than the 1p19q status, and you just have to remember ATRX loss pairs with the other one, the astrocytoma, whatever works to make it stick.
Perfect. IDH-ONE, it is. Okay, so armed with this, let's go back to our 42-year-old man. Frontal lobe mass, subtotal resection. The final path report lands on your desk. It reads, histologic grade 3, IDH mutant, and 119q co-deleted.
Okay, grade 3, IDH mutant, 1p19q co-deleted.
So, using our shiny new integrated diagnosis framework, what is this and what's the next step?
All right, piece by piece. IDH mutant, 1p19q co-deleted, that tells us it's an oligodendroglioma. Histologic grade 3 tells us it's anaplastic. So the integrated diagnosis is anaplastic oligodendroglioma, WHO grade 3.
Got it. Anaplastic oligo grade 3. Now we know exactly what we're treating.
Precisely. And now that we have that specific diagnosis, we can look at the high-level evidence. For this specific tumor, grade 3, IDH mutant, 1p19q co-deleted oligo, the standard of care is defined by two absolutely pivotal phase 3 trials.
The ones you mentioned earlier.
Yes, EORTC 26951 and RTOG 9402. Both basically asked, for these patients, does adding PCV chemotherapy to radiation therapy improve survival?
PCV. Can you quickly remind us what's in that chemo cocktail? It sounds pretty heavy duty.
It is a potent regimen. PCV stands for procarbazine, CCNU, which is lomustine, and vincristine.
Procarbazine, lomustine, vincristine. Okay.
Yeah, procarbazine and lomustine are oral alkylating agents. They damage DNA. Vincristine is the Fantity. It messes with cell division. It's effective, but it definitely comes with side effects, especially hematologic toxicity impacting blood counts.
Right. Not a walk in the park. So Let's own EORTC 26951 first. How is that trial set up?
Okay, EORTC randomized patients who had, at the time, what was called Anaplastic Oligodendroglioma, or Anaplastic Oligoastrocytoma.
That old mixed diagnosis again.
Right. They randomized them to get either radiation therapy alone or radiation therapy followed by 6 cycles of adjuvant PCV chemo after radiation.
And the radiation dose.
Standard dose, 59.4 gray in 33 fractions.
Okay. What were the key findings, especially when they went back and looked with the molecular data?
That's where it got really interesting. The long-term update, incorporating the molecular subtypes, showed a clear overall survival benefit for adding PCV. But the kicker was, this benefit was driven entirely by the patients whose tumors had the 119q co-deletion.
Entirely. So no benefit for the intact group in that trial.
Essentially, yes. The benefit was concentrated in the co-deleted subgroup. For those patients, adding PCV was a game changer.
How much of a game changer? Quantify that massive benefit for us.
Okay, get this. For the co-deleted group, adding adjuvant PCV boosted the median progression-free survival time without the tumor growing from about 4.2 years to 13.1 years.
Wow, from 4 to 13 years PFS. That's huge.
Incredible difference. And median overall survival jumped from 9.3 years with radiation alone to 14.2 years with the combination.
9.3 to 14.2 years median survival, nearly 5 extra years.
Yeah. In brain tumors, that kind of survival improvement is, well, massive. It truly redefined the standard for these patients.
Unbelievable data. Okay, that's EORTC, adjuvant PCV. Works for co-deleted oligos. What about the other big one, RTOG 9402? Did it ask the same question?
Similar patient population again, mostly anaplastic oligo and oligoastrocytomas. But RTOG 9402 tested a different sequence. They compared radiation alone versus neoadjuvant PCV, giving the PCV before the radiation.
Okay, chemo first, then radiation. How did that one pan out initially, before they had the molecular data?
Well, this is a fascinating story in clinical trial evolution. When RTOG 9402 was first published back in 2006, it was considered a negative trial.
Negative. How so?
It showed no significant difference in overall survival between the arms. Median survival was something like 4.7 years versus 4.6 years, basically identical. So the initial conclusion was, well, maybe adding PCV doesn't really help this group overall.
Huh. So initially, one trial positive, EORTC long-term, one negative RTOG initial. That must have been confusing.
It was. But then came the molecular reanalysis years later, applying the IDH and 1p19q status retrospectively to the patient samples.
And this is where the picture flips completely, right? Like cleaning off an old painting, you said.
Exactly that analogy. The reanalysis results were profound. They looked specifically at the 119q co-deleted subgroup within RTOG 9402. And in that subgroup, adding the neoadjuvant PCV almost doubled the median overall survival. It went from 7.3 years in the radiation alone arm to an incredible 14.7 years in the PCV plus radiation arm.
14.7 years. So almost identical long-term survival benefit, as seen in EORTC, just achieved with a different sequence.
Precisely. 7.3 years up to 14.7. What was initially a negative trial became incredibly positive once they could identify the right patient population using molecular markers. It was just hidden by the mix of patients in the original analysis.
So the message from both EORTC 26951 and RTOG 9402, viewed through this modern molecular lens, is crystal clear.
Undeniable. For patients with anaplastic oligodendroglioma defined now as IDH mutant, 1p19q co-deleted, adding PCV chemotherapy to radiation dramatically improves survival.
Whether you give the PCV before radiation or after radiation, that combined modality approach is the standard of care, yielding median survivals over 14 years.
That's the bottom line. Robust benefit, established standard.
Okay, so the evidence supports chemoradiation, but clinically, you have to choose. Neoadjuvant PCV first, like RTOG, or adjuvant PCV after radiation, like EORTC. Which way do most centers lean, and why?
That's the practical question. Most centers, and the NCCN guidelines reflect this, tend to favor the adjuvant approach from the EORTC trial. Radiation first, then PCV.
And the reasoning behind that preference? Is it efficacy or something else?
It mostly comes down to tolerability and feasibility. That dose-intensive neoadjuvant PCV used in RTOG 9402, it caused a lot of hematologic toxicity.
Right, the blood count issues you mentioned.
Yeah, significant myelosuppression. A substantial number of patients actually couldn't complete all the planned cycles of chemo before radiation because the side effects were too severe.
So giving it up front was just too tough for many patients.
Exactly. Giving the PCV after radiation in the adjuvant setting seems to be generally better tolerated. Patients have recovered from surgery and RT, their marrow reserve might be a bit better, and more people tend to complete the planned treatment. So it's about delivering the effective therapy in a way most patients can actually receive it.
Makes sense. Maximize the chance of getting the full treatment in.
Mm.
Okay, one more clinical point here. The PCV toxicity is still a concern, even adjuvantly. What about substituting temozolomide, TMZ? It's oral, generally much easier to take. Is that a reasonable swap for PCV in these patients?
That is the big question right now, and a source of debate. It's being formally tested head-to-head against PCV with radiation in the ongoing CODEL trial. We're eagerly awaiting those results.
So no definitive answer yet from a phase 3 trial specifically asking that question.
Not from CODEL yet. However, we do have some clues from other studies. The German NOA04 trial, for instance, compared RT, PCV, and TMZ in anaplastic gliomas.
And what did it suggest for the oligos?
It suggested that for the 119q co-deleted tumor specifically, PCV seemed to be superior to TMZ in terms of progression-free survival.
Interesting. So preliminary signals favor PCV's efficacy in this specific group.
That's the current interpretation of the available data. So while TMZ is appealing for its better side effect profile, PCV currently remains the evidence-based standard chemo backbone for anaplastic oligodendroglioma based on proven survival benefit from EORTC and RTG, and hints of superiority over TMZ from NOA04. We need CODEL to really settle it.
Okay, so PCV is still the champ for now, evidence-wise. Got it. And just to reiterate the radiation part you mentioned, the dose used in EORTC was 59.4 gray and 33 fractions. That specific dose remains the standard we aim for.
Absolutely. That's the dose proven effective in combination with PCV in the trial that showed the survival benefit. We stick to that dose and fractionation 1.8 gray per day to ensure we're replicating the conditions under which that benefit was demonstrated. Precision in radiation delivery matching the trial parameters is key.
Great. Okay, I think we've covered the diagnosis and the evidence really well. Shall we try putting it into practice with a few quick cases? Time for our board blitz.
Let's do it. Always good to apply the knowledge.
All right. Case 1. 45-year-old woman, subtotal resection of a frontal lobe tumor. Pathology is back. Anaplastic Oligodendroglioma, IDH mutant, 119q, co-deleted. What's the most appropriate management? A, observation with serial MRIS. B, radiation to 59.4 gray alone. C, radiation to 59.4 gray, followed by adjuvant PCV chemotherapy. Or D, TMZ monotherapy.
Okay, grade 3 oligo, IDH mutant, 1p19q co-deleted. Based on everything we've discussed, the clear answer is C.
C, radiation followed by adjuvant PCV.
Absolutely. This is the classic high-risk grade 3 oligodendroglioma profile. EORTC 26951 and RTOG 9402 established combined modality with RT and PCV as the standard, showing that major survival benefit. Observation, R2 alone or TMZ alone would be undertreating this patient based on level 1 evidence.
Perfect. Standard of care is chemoradiation. Okay, case 2, testing the diagnostic algorithm. 52-year-old diagnosed with an anaplastic glioma. Molecular report shows IDH mutation, 119q intact, and loss of ATRX expression. Which statement is most accurate? A, it's an anaplastic oligo, treat with RT plus PCVB. It's an anaplastic astro, treat with RT plus PCVC. It's an anaplastic astrocytoma, and treatment should be based on the Catnon trial. Or D, it's a molecular GBM, treat per step protocol.
Okay, let's use our algorithm. IDH mutant. Yes, 119q status intact.
Okay, so that rules out oligo.
Right. IDH mutant plus 1p19q intact astrocytoma. The loss of ATRX confirms this.
Yeah.
So we know it's an anaplastic astrocytoma, IDH mutant. Therefore, treatment isn't guided by the oligo trials, EORTC, TCR, the GBM protocol stuck because it's IDH mutant. It's guided by trials specific to anaplastic astrocytoma, the main one being the Catnon trial. So the answer is C.
Excellent breakdown. C is correct. It's an anaplastic astrocytoma, and Catnon guides treatment. Okay, last one. Case 3. You're discussing RTOG 9402. What's a key finding from that trial specifically for anaplastic oligodendroglioma? A, TMZ was superior to PCVB. The trial was positive initially in 2006. C, neoadjuvant PCV plus RT improved median OS to 14.7 years in the co-deleted subgroup. Or D, RT dose escalation to 70 gray improved local control.
Okay, thinking about RTOG9402 and its impact on oligos. Option A is wrong. TMZ wasn't tested in that trial. Option B is wrong. It was initially published as negative. Option D is wrong. Dose escalation wasn't part of 9402. That leaves C.
C. Neoadjuvant PCV followed by RT improved median OS to 14.7 years in the co-deleted group.
And that is absolutely the key finding. The molecular reanalysis revealing that dramatic survival benefit from 7.3 to 14.7 years in the chemo-RT arm for co-deleted tumors is the lasting legacy of RTOG9402.
Fantastic. Great job working through those. So let's try to quickly summarize today's session. We really built that essential molecular framework for high-grade gliomas.
Focusing on IDH status first, then 1p19q status for the IDH mutants.
Right, and we saw how that framework directly applies to defining and treating anaplastic oligodendroglioma. The key takeaway has to be that modern diagnosis is molecular.
Absolutely. And anaplastic oligodendroglioma is specifically IDH mutant and 1p19q co-deleted. That's the definition.
And for treatment.
The standard is clear based on those two huge trials, EORTC 26951 and RTOG 9402. Radiation plus PCV chemotherapy provides a major survival benefit, pushing median survival over 14 years.
An incredible outcome, really, for a primary brain tumor established by understanding the underlying molecular biology.
It truly highlights the power of precision oncology.
Definitely. So as we finish up, this naturally leads to our next questions, doesn't it? We've covered the grade 3 oligos. What about the grade 3 astrocytomas, the IDH mutant, 1p19q intact ones? How does that Catanon trial, pronounced Catanon, right? How does that guide their management?
Yes, Catanon is key there. And there's another layer now, too. The newer WHO classification recognizes IDH mutant grade 4 astrocytomas. That's a relatively new entity based on specific molecular features like CDKN2AB deletion, even if the histology looks grade 2 or 3. How do we treat those?
So even more complexity emerging. Lots to cover next time then. Anaplastic astrocytomas, Catanon, and these new grade 4 IDH mutant astros.
Plenty to discuss. The field keeps moving fast.
It certainly does. Well, for more practice, remember to complete practice oral boards at radoncSmartLearn.com. That's radoncSmartLearn.com. And subscribe to Rad Onc Smart Review for our next episode, diving into those astrocytomas. Thanks for tuning in.
Thanks, everyone.